Welcome everyone to week 3 of DDU cases. We are very, very lucky today to be joined by Yang, who is an intensivist at the Western Health in Victoria, and is also head of the DDU exams for crit care. So this would be an awesome session, and yeah, thanks very much for joining, Yang and everyone else. So we'll get started. Thank you.
Thanks, Emma. Look, we're going through some of the sort of mock exam questions. The reason that these questions became mock exam questions is because they're unfit for real exam questions. So some of them may be too easy, some of them may be too hard. And that's why we sort of, while we're accumulating cases and then selecting cases, that we put those cases into the mock exam. So I can reassure you that not almost every cases that you see today are unlikely to going to be in the next exam. And if you find the cases are slightly outside of your knowledge base, that's totally fine, because it's not going to affect your exam as well. If you find the cases are super easy, it's not really a guide for you to, based on this level, to prepare your exams as well. This is mainly a practice about what the formula of the exam is going to be look like, and also a practice of when you, in the exam, if you are facing a situation that you're not familiar with, that how are you able to deal with a stress situation and still trying to score the highest as possible. Okay, so are you ready for the challenge?
No, I'm not.
Who wants to go first?
Yeah, I'll be happy to go first.
Okay, all right. We have 7 cases today, so you all have a chance, so don't feel bad about it. We are going to, let me see, I'll minimize this. I'll minimize this, I'll put it somewhere. Okay, so this year will be similar format as you start your exam, that you will have, you know, like a assessment, oral assessment, what date is that? And then the first case are point and shoot style questions. So these are point and shoot style questions, means that they're very simple. They usually have a little, not much wording about the theme of the question, and they will have 1 or 2 pictures for you to see and to interpret. And they can be with cardio, lung, or any other things that cover the whole DDU sort of topics. So what does this MO tells you?
Yes, it's M-mode across aortic valve. I think there's early systolic closure of the aortic valve. It could be from LVOT obstruction or aortic stenosis.
Very good. Is there any other things that you see on the?
Yeah, there's a
MO?
fluttering of the right coronary cusp. I'm not really sure the reason for that.
Okay. Next one.
Yeah, I'm concerned about a patent ductus arteriosus. There's a color flow Doppler abnormality connecting the aorta, descending aorta and the pulmonary trunk.
Very good. Okay, the third one. What does this image tells you?
So that's a color flow Doppler across LV in 2-chamber view. It's significantly hypertrophied, and I think the findings suggestive of hypertrophic obstructive cardiomyopathy, as well as other diseases that can cause significant hypertrophy, such as infiltrative disorders, such as amyloidosis, metabolic sort of storage disorders.
Yeah, you've been describing sick heart in general, but in particular to this case, what subtype is this?
Yeah, so that looks like ace of spades. The exact subtype escapes me, but yeah, it's an apical variant of hokum.
Okay, next one. There is a toe image. You've done a toe and you find a heart look like that.
Oh gosh, okay. It's a very abnormal transesophageal echo, mid-esophageal four-chamber view. There's a large 2D defect across ventricular septum, as well as a sort of positive bubble study. It's highly suspicious for a large hemodynamically significant VSD. LV looks very, very, very thickened.
Okay. Can you tell which valve is mitral valve, which valve is tricuspid valve? For example, the pointer right now.
Yeah, so I think that's a tricuspid valve of the traditional orientation of mid-esophageal four-chamber, as well as the annulus sits a bit higher than the mitral valve, which makes it more likely to be tricuspid valve.
Okay. Next picture. Critically analyze this image.
Yeah, I think that's sort of an attempt at tissue Doppler across the medial annulus of the mitral valve. First of all, I could improve the cursor position. It should be lower at the mitral valve leaflet insertion point to the septum. It's a bit too higher on the image. And the Doppler gain, firstly, the scale can be reduced further. It scales up to sort of 14 on either side. It could be much lower than that. And the gain can be reduced to minimize a sort of spectral broadening artifact.
What does this tissue Doppler actually tells you?
Yeah. Oh, yep. And the I mean the E velocity is sort of severely reduced. At the normal cutoff would be 7, and this one's at 4. But again, because I think the quality could be improved. I'd like to get a better measurement and look at it again.
So I think this will be the end of case 1. So before we move on to the next one, I think we probably just revisit the case, and then if other candidates have anything to add in for those cases. So we come back to this one. That's the last question.
Yeah, oh, that was pretty tough. Sorry, I think Rishi has a comment.
I think on the 2D there is looks like a thickened, infiltrated myocardium wall. On the tissue Doppler shows all the velocities are less than 5. So it could be
Of course, yeah.
In hematosis.
Yes, very true. Thank you for adding that additional bit. That's and the rest of your answers are all sounds very reasonable. So this is a very hard case, as we don't usually see a heart look like that. Like I have to say that debating between the diagnosis of VSD versus a diagnosis of single ventricles, that this is probably more towards a single ventricular rather than the VSD. Like there is no ridge, like there's nothing here to sort of like this is literally just one ventricle instead of VSDs. But I won't blame you that how many times we see a heart look like that. So it's literally just to show you that if you see something you totally never seen about, then you can still get something out of it. I think you won't be I think it won't be too wrong if calling that a VSD, but still saying it's totally abnormal and describe what you see.
Yeah, yeah.
If you are not certain at the time, particularly when you start to say, like you think this is a tricuspid valve because it sits a bit higher than the mitral. I was like, what do you mean? You mean by here? That's higher though. Or you mean by there? That's at the same level. So what do you actually mean by that? So so stay to what the picture is. It is actually quite hard to tell which side is which side. But this case I remember is actually a hypertrophic left heart. So this whole thing is a left heart and hypertrophic. And then it's, if you actually look at the valve itself, you just see so many redundant tissues, and also that's a second RV there, like because it's actually functioning like the ventriculus at the LV here, so that's why. But however, that if you see something that abnormal, I like the way that you acknowledge it. This is very abnormal. That's a great start. And then just describe what you see. But
Sure.
This one is probably more towards the single ventricle than a very, very large VSD.
Yeah.
Okay. All right. This one, I have nothing more to say. I think it's quite well defined, and then you correctly say that's an apical variant of Hockham. Great pickup. That's fantastic. And this one, I agree with everything you said about this missystolic closure. So looking at this case, for example, you have 5 pictures, and then you probably answer 3 all very correct, and then you answer 1 probably not that correct, but it's not totally wrong, as such as you say that's a normal heart. And then the last one had a little bit there, so you will still very likely score a pass for that question. Does that make sense for the exam? That's how the scoring system is. Unless you make a critical error, for example, like you answer all this right, but however that you come and tell me that this is a normal heart, then I think you will hit the critical error. Then if you hit the critical error, then you likely will be marked as a fail for that station. Okay. Any questions before we move on to the next case?
So, just a quick question with that image on the screen.
Yeah.
That on the wall, is that a myocardium or a how would you describe that? The wall on the ventricle, is that just a hypertrophic myocardium or a tumor or organized?
You mean all of this? Yeah, that's
yeah.
the hypoplastic heart. Yeah.
Hypoplastic heart.
Yeah, so actually, if you actually look closer, most likely this need to be the septum in the past, but it just became a little blob there. And then this whole area here just not developed.
Okay, thank you.
Okay. All right.
Thank you.
Thank you. All right, are we ready for the next case? Who want to take on the next case? Maybe it's not going to be as hard as the first case.
I can go, yeah.
You can try, okay. All right. So this is a 62 years old man presenting with a reduced exercise tolerance, fatigue, and short of breath on exertion. The ED call saying that the patient had a borderline hypotension and wished to run past by you before sending to the ward. They said that he's just sitting about 90, systolic. It's not that bad. You insist to do an echo before the patient is transferring to a ward bed. So you went down with your machine and the patient is literally about to be transferred from the trolley to the ward bed. And then the nurse in charge in ED tells you, please hurry up. We are already over 4 hours. That don't do your echo for another hour. So you quickly put your probes on, and then this is what you see.
Right.
Can you please describe what you see?
So parasternal long axis and short axis images. The most obvious finding is a dilated and severely impaired left ventricle. On the parasternal long axis, you can see the patient is in sinus rhythm. I cannot see any obvious B lines on the screen, but the LV size appears dilated and LV function appears impaired. RV outflow tract function appears impaired. The size appears normal compared to the aorta and the left atrium. Left atrium, I would like to compare in other views, but appears mild to moderately enlarged. On the parasternal short axis view, with the color Doppler, I can see the LV function is impaired with a regurgitant jet across the probably A1 or A2 to P1, P2 scallops.
Anything else you can see on those two pictures?
And there's obviously regional wall motion abnormalities. The anteroseptal wall appears akinetic. The inferoseptal wall appears hypokinetic. And may be severely impaired left ventricle. RV size appears normal on the personal short axis, but the images are not clear. I'd like to see them in other views, but there does not appear to be any marked septal flattening at this stage.
Okay. Please describe what you see here. That's other views you request for.
So the full chamber views confirms a severe systolic dysfunction. It is not exactly at the true apex on the full chamber, but LV size appears enlarged, although it's not the best view to comment on. LV function appears severely impaired. Left atrium is moderately dilated. The RA-RV size appears normal, but RV function, the lateral wall function appears impaired. There appears to be either a pacemaker or an AICD device in situ. On the LVOT pulse wave Doppler, the VTI the VTI appears to be this it is 16, which is close to around moderate. And cardiac output seems to be maintained at this stage.
Okay. So this tells you.
So there appears to be mild mitral regurgitation based on the density of the colored jet. The waveform is not complete, so it's not possible to completely comment on it. But based on the densities, I would say it is mild. But this image could be optimized even further by increasing the scale and attempting any off-axis view to get a complete mitral regurgitation jet.
What else do you see on this apart from the mitral regurgitation jet?
There appears there's no diastolic component of the mitral regurgitation I can see. The forward flow, there appears to be ENA waveforms which are there at this stage. Yeah. The mitral inflow and the tissue Doppler velocities. The E velocities are within normal range. Based on the tissue Doppler, the E by E prime is more than 15, and the E velocities are the septal E velocities are reduced, which is consistent with reduced LV function.
So based on this very limited assessment, do you think the diastolic function is normal?
So with the septal E prime being reduced, I would say it's not normal. But I mean, the LA size is not measured. I would need more information to comment on the diastology. But with the impaired LV function, with reduced septal E prime velocities, I would say definitely it's not normal. but at the same time, it does not appear to be severely impaired still.
What do you think about this person's filling pressure?
This is going to be elevated, but I'll need to measure the, and the E by E prime is elevated. I will also need to measure the tricuspid regurgitation and the LAVI.
Mm-hmm. What do you see here?
So it shows the IVC appears small and is collapsing, and the hepatic vein Doppler, which shows predominantly a diastolic forward flow. Which makes me feel that the RA pressures are with normal limits.
Mm-hmm. So finally, shall this person go to the ward?
I think he should be managed in CCU or ICU. He's someone who is presenting with shortness of breath, likely to be a cardiogenic cause. This patient has severely impaired LV function with features of raised left-sided filling pressures, and that could explain the shortness of breath. So this patient should be managed with a diuretic infusion plus minus inotropic supports. I will need further information in terms of his clinical appearance and the biochemical picture, including lactates and renal functions.
Okay, thank you very much. That's the end of case 2. All right. Before we move on again, any comments from other candidates about case 2? So we go back to the STEAM. I think the STEAM is quite long. It gives you a lot of information. It tells you that this person actually have symptoms of heart failure, and then he had borderline hypertension. He's certainly not classic, people already on anotropes or require intubation. So therefore that the question arises whether he can actually go to the ward. But however, you done an echo and you actually find something that was not really expected. Well, you first see that, those vitals. Clearly, I agree with you that it's showing a really dilated, chronic looking global LV dysfunction. Any other add-ins there for those 2 pictures? And RV dysfunction, I agree. The valve looks like a bit normal. The only thing to say it's mitral valve a bit tethered because of the dilated annulus. I do think you can quite confident to say this one looks very chronic. It's thin, dilated. And then on this one, that I was hoping that someone pick up here with a pacing wire or defibrillator lines here in the RV. But however, these are minor. Like, it's not going to affect you whether pass or not, because even if you don't see that there, you already see that in the next picture. So it's not going to be too much. But if you tell me this is a normal LV, then that would be a critical error. Then you will be immediately for. The next picture, similar things that showing you that this person is probably at risk. So a Sky Class B. Certainly not in shock yet, but pre-shock. So you got a terrible heart here. You got the RV with maybe a defibrillator or a pacing wire. Looking at the thickness, it's probably more like a defibrillator. And then you still got a VTI maintaining at about 14, not saying 16. Not saying 16 is normal, but however, it's not less than 10. So so it is bad, but not sort of the worst that you can see. And then here, I was hoping that there are some comments on this wave here.
Oh, the L wave.
Yeah, that's what you see with terrible heart failures. And then here again, you got similar appearance here as well. And although this is a normal looking sort of filling patterns, but actually because, and you did mention that because of severe LV dysfunction, that likely this patient will have diastolic dysfunction. So finally, interesting bit is that you may be expecting a very dilated IVC and also probably a reversal of, you know, like with TRs and things, but we're not saying all of this. And so it's probably these are the ones that are difficult, because a lot of time we're quite familiar with those you know, APO and acute heart failure, volume overloaded. But these ones are actually give you a picture of a chronic sort of heart failure and then progressive. Maybe already on a lot of treatments for that. And then so therefore they're actually quite euvolemic. They're not that sort of overloaded. And the other thing I think we do need to be cautious about when we interpret right-sided pressures, that the right heart function is impaired, but it's probably not that bad yet. And a lot of time that, you know, like we see more pulmonary congestions in left-sided heart failure, and then more, you know, like livers or kidneys, like those sort of abdominal organ congestions or even peripheral edemas in the right heart failure pictures. So therefore that sometimes you may hear a lot of people saying that, oh, there is no edema and it's unlikely heart failure. Actually, that's not exactly what it is, because acute left heart failure is actually, if you look at those people, they're not edematous at all. They got APO. That's acute left heart failure. Acute right heart failure, you do have edema. Certainly biventricular failure, you will have, you know, peripheral edemas. So therefore, they're looking at these patterns that this person is probably actually euvolemic rather than, you know, like rather than overloaded. But however, the left-sided filling pressure is increased, as the Doppler suggested. I don't really have any more to add on this case. I think it's clearly a pass by what you have done. But if you want to score excellent pass, then you probably do need to mention about those L waves and, you know, like the pacing wires and those sort of little things. And maybe have a bit more discussion about the filling pressures, particularly when the left side and right side doesn't appear to be consistent. Yeah. Does that make sense?
Yes, thank you.
Thank you so much. All right, so Rob, don't think you can escape this one now. Here you go.
Ready as I'll ever be.
Ready? Okay. So case 3, history, a 71 years old man presented with a STEMI. He had an ECPR on the table and he was successfully revascularized after that. Day 3, ICU on the ECMO support with downtraining inotropes. So there are a question regards of whether this person is able to be weaned from the ECMOs. So describe these findings, please.
Yep, so we've got X-plane mid-esophageal 4-chamber view. So we can see that the LV function is, LV systolic function is probably at least moderately impaired, with the majority of the function appearing to be coming from the basal segments of the heart and akinetic apical segments. So the inferior septal base appears to be thickening better than the other portions. And then looking at the X-plane, so this will be the anterior and inferior wall. Again, the basal segments appear to be having the most function with an akinetic apex. So this would be consistent with a large LAD infarct that the patient's probably had. I can't really comment too much on the RV function, but the components that I can see appear preserved at this stage.
Any other comments on this picture?
So there is an echo density towards the apical segment, which I'd like to interrogate in other views. With the STEMI and the akinetic segments, the patient would certainly be at risk of an apical thrombus. So it would be nice to see that from other views to see if that is indeed a thrombus.
Okay.
So now we've got the mid-esophageal, looking at the long axis view. Again, mostly preservation at the basal segments. So this will be the anterior septal wall that I can see best. Still hypokinetic. There is a mild degree of mitral regurgitation, which is associated with that. Looking across the LVOT, so zoomed in with color flow Doppler, appears like the aortic valve is opening normally. There's no aortic regurgitation.
Okay.
It doesn't appear like there's any obstruction. Yep. So this is transgastric view now. So sort of, I'm assuming we're at sort of at the basal to mid segments of the heart. There's a lot of movement artifacts, so it's difficult to comment on the regional wall motion abnormalities, but you can see that there's, at least from this view, it looks like there's severe systolic impairment with minimal fracture.
Are you able to name the walls in this view?
Yes, certainly.
Like
So
I'm pointing, what is this one?
So that's the anterior wall. So opposite to that will be the inferior, and then we have that'll be inferior septal, and then if you went around, I can't see where your mouse is now. Sorry, Yang. That's anterior septal, and then we have that's the inferior lateral, and then anterior lateral wall.
And which portion of the heart is hypokinetic or akinetic, as you described?
So I think we're at the sort of at the basal segment, and I think from this view it's difficult to comment. With all that motion artifact, it's difficult for me to comment, but I think in the other views it appeared like the basal segments had the most activity and the apex was akinetic.
So is this the base or this is the apex? Where is it?
Well, this is not the base because I would see the mitral valve, so we must be more towards the apex.
Very
Yeah.
good. Okay.
I
And the
can't-
BTI?
Yeah.
Sorry, yeah. And there is no clot there. Okay.
I can't see any
VT
clot. Yeah.
Good. VTI is 23.4.
23.4.
Yeah.
Well, I'd be concerned about whether this is a true representation. So it looks like we've done this from a transgastric view at not the deep, but just a standard transgastric view at 120. There's a reasonable amount of spectral broadening there. So there could be some overestimation. I mean, 23.4 is a normal VTI / on the high side, but I don't think that's consistent with the pictures that we've seen. So I think there's possibly some, it doesn't appear to me like a good trace. I would normally expect to see a closing click of the aortic valve, which I can't see, and I'd like to see an enveloped sort of trace with where it's blank or black in the middle, which I can't see. So I'm concerned that there's spectral broadening here, but it's a inadequately taken VTI for the LVOT.
It is actually, it's continuous though.
So it's continuous.
Yeah, so you won't see the
yeah, of course. In that case,
Oswald Doppler type of Dopplers. Yeah.
Yeah, of course. Sorry. Yeah, I'd like to interrogate the valve in that case and make sure if there's any stenosis of that valve, because it's a little bit on the high side given the function. What is your next step to manage the patient?
Yep.
Well, so this patient's on VA ECMO support with 2.5 liters, I think you told me, with concerning LV systolic function. I don't feel like I've got a full study to assess whether they're weanable or not, but I'd like to look at, I'd like to assess the heart completely to be able to make that assessment.
Okay, well, you further assess, you drop the flow down to 1.5.
Yeah.
And this is what the heart look like at 1.5.
So with assessment at lower flows, it appears like there's some improvement in the myocardial function, which could be in the setting of increasing preload conditions. So I'd say the segments that I can see here are still hypokinetic, but they're certainly improved from earlier. And then again, you're showing me, sorry, a continuous wave aortic valve VTI, which has increased in velocity if we are to believe that the trace has been done correctly, which it's not quite. The trace goes beyond the closing click of the aortic valve, so it's an overestimate, but is consistent with the 2D changes that you've shown me.
Okay, And the number is 28. We can
Correct.
blame the anesthetist or whoever done the study. That's okay.
Yeah.
But at least the number is 28. Okay.
Yeah.
And now,
So clamped, so presumably you're saying we're off support now. So 2D picture, cross-plane again, so mid-esophageal 4-chamber and 2-chamber. Again, I think there is a mild improvement in the systolic function of the LV here with reduced flows. So there's been some recruitability with that increased preload conditions. And then we've done the aortic valve VTI, which is back to 22. Again, it's not a great trace. And it's not usually the number that I would use to estimate stroke volume or cardiac output, but it does imply that we're getting, assuming there's a normal aortic valve, it implies we're getting reasonable velocities across that valve.
I think you did see the aortic valve before, did we?
Did we? Yes, we did.
I can remind
commented.
you.
I even commented on it. Sorry. Yeah. So
Yes.
you're right. So there's no stenosis to that valve. So I think this is a promising value in that setting.
So do you think the patient is ready for explant?
Well, from the images you've shown me, I haven't seen the RV well, but it doesn't appear from these images like the RV has dilated or has become impaired with the increased loading conditions. And the LV appears to be tolerating it well. So from the images you've shown me, it appears like they could potentially be weanable. I would normally also like to, like I said, assess the RV and just make sure. We saw that, great. So,
sorry. Yeah, so you're going to assess the RV and all the others and looking at the whole picture rather than just based on the echoes?
Correct, yeah.
And then this is on your way out, then you sort of, like you always do the aorta on your way out. So what is actually, what's happening?
So we're at 0 degrees and we're looking at the aorta. Now, the aortic wall looks like there's some calcification there, / I'd be concerned whether there's dissection, which can happen with patients who've had, now I can't remember the history, but we've had wires in the aorta to put the patient on ECMO, so it's potential that you could have caused that. I'd like to look at a reduced depth. There's also, now I don't know what depth we're at, but there's some fluid around the aorta, which I think we're probably looking at pleural effusion here around the lung.
And then the lung itself?
The lung itself is also collapsed, which would be consistent with the pleural effusion. There's some B lines within the lung, but there's also collapsed components as well. You can see some hepatization there.
Okay, end of case 3. Thank you very much. Any other add-ins from other candidates? Okay. So we go through that. First of all, you won't have such a case in your exam. I think that, but it doesn't really matter what the STEAM is. Like, we still return to the basic. That most likely when you got show a ventricle with a biplan view, that will ask you about regional walls and heart functions, and you correctly spell all of those things. I do agree on that one that there is a bit of suspicious there, but later on we didn't see that clot. That just be very familiar with yourself about the walls and where are they, and also, mitral valves and which leaflet are we looking at in different views. This is not a valvular question, so we didn't ask you in detail about the part of the valves. It's mainly about AMIs and heart function, so we ask you about the walls and what's the wall function and all of that sort of thing. I do agree with everything you said on that, but just remember that when when later on that you say something that it's still the same patient. So if you already said the aortic valve is normal here, then later on you said that, oh, if he has significant aortic stenosis, that sounds a bit odd as well, you know, because we already see the aortic valve. And in real life, when you report a scan, then you will not say, oh, the aortic valve is normal. In the absence of aortic stenosis, that I would assume that, you know, it's like, you know, it just sounds a bit odd that it's so remember what you already said and what you already see.
No,
Yeah. I have to prompt you here a little bit. You didn't see the pap muscle, it's not the mid. You didn't see the mitral valve, it's not the base. So it is the apex, and the apex is look like that, didn't move. I don't know why continuously that they're using the AV BTI rather than the LVOT VTI. I think it's probably just a habit. But however, all the numbers, although I agree with you, it's probably not the best measurements, and the angle is probably not exactly correct. However, they are consistent, and they're not really those sort of alarming features and saying that they're terribly bad.
Yeah.
Keep going. How to next step manage this patient? Then you say, oh, we'll try to win and get some more numbers. So here you go. They try to win and get some more numbers. And then this is most likely it is expandable, but certainly you did mention very well that it's not just based on echo. You need to look at other things as well. So that's all very well described. Here, I think we just need to be careful not to overcall. Like it's okay to say that I'm suspicious of a dissection, but this doesn't look like dissection at all. Like there is no free flapping or anything like mobile moving there.
Yeah.
I need to prompt you about the lungs.
Yeah.
Yep. So therefore that I think that when you see something obvious, it's this perfusion. But if you want to score really, really high, then you can also say that, well, I will be concerned about oxygenation when this person off. He has such a big perfusion. I probably want to deal with this first and then make sure that oxygenation is okay before I take this person off the oxygenator. Something like that. That will probably showing a degree of maturity about not just seeing the pictures, but also like you have some thought process going through that of what you see.
Yeah.
Yep. Are we all happy with that? Emma, do you have anything else to add on this one?
No, yeah, nothing from me.
Hey,
Well
all
done,
right.
everyone, so far.
Thank you. All right, so there are more to come. So we're back to Hao-Won. Is that correct? Is that correct to spell your name?
Yep.
Hao-Won.
Yep.
We're back to Hao-Won. Are you ready, Hao-Won?
Yep.
Oh, this one. Oh my God. Okay, so there are 65. A female post-cholecystectomy, a MECO in recovery with severe hypotension and APO, so terrible. You're attending the code and then perform an echo. Please review the slides. There are about 6 slides.
Yeah. Yeah. So what strikes me the most is hyperdynamic LV function with significant flow turbulence around the LVOT, as well as suggestion of significant MR. Yeah, I think they're the most salient findings here.
Any other additional findings?
Yeah, so going through a bit more systematically, mitral valve, I'm concerned there may be a systolic anterior motion, but I'd like to look at it with a zoomed in view of the mitral valve. Difficult to comment about aortic valve, although there doesn't seem to be significant regurgitation, but I'd like to look at a zoomed in view and other Doppler parameters. The RVOT appears unremarkable. Perhaps there's a bit of echogenicity in the adjacent to the RVOT. That could be pericardial fat or trivial pericardial effusion. Yep.
The ventricle itself?
Oh yeah, significantly hypertrophied, both anteroseptum and infralateral walls.
So what are you seeing here?
So yeah, I think this is an M mode across mitral valve. I think this does show systolic anterior motion there. Yeah, so the anterior leaflet of the mitral valve comes in contact with the septum during systole.
Oh, you mean this one here?
Yeah, or maybe for the next cardiac cycle.
This one?
No,
This one?
yeah, that one was what I was looking at. Yeah. And some earlier cycle as well. Actually, no, that's probably the only one. But I mean, I think combination of 2D and color Doppler finding, I'd still be worried about LVOT obstruction.
Let's look for that.
Yeah. Yeah, so firstly focusing on the 2D image. Look, I like to slow it down, but I mean, knowing what I know now, look, I'd be highly suspicious that there is systolic anterior motion. Yeah, especially there where you just stopped. And again, sort of significant flow turbulence, posteriorly directed MR jet in the setting of hypertrophied and hyperdynamic LV. And the clinical picture of APO and hypotension post-op, patients likely to be hypovolemic, maybe a bit vasodilated. So I think that'd be my primary concern.
Okay, describe the Dopplers.
Yeah, I think so. That's a continuous wave across mitral valve, and I think I'm looking at sort of multiple Doppler waveforms superimposed on top of each other. I think on the second, the cardiac bit,
Let's start with this.
Oh yeah, so that's some mitral inflow. Again, I guess again I'd like to do a measurement, but I think E to A ratio is going to be more than 2, just based on that. So suggestive of diastolic dysfunction, grade 3 diastolic dysfunction, and raised LAP, or it could also be due to MR.
This one here.
Yeah, so that parabolic broad jet that starts immediately after mitral inflow, I think is the MR signal that I'm looking at. And then I think afterwards, I think there are 2 signals that maybe there's multiple points of obstruction. So the one with the high velocity with dagger-shaped waveform is typical of dynamic LVOT obstruction. Although what's unusual is that the velocity of that is a bit higher than the MR jet. But there's a shorter waveform again that's late peaking. So there could be an obstruction elsewhere, perhaps in the mid-ventricle, given the significant hypertrophy.
Very good. All right, next one. What's your management of this patient?
Yeah, so the management would be sort of further fuller resuscitation in the first instance. That'll alleviate the LVOT gradient and also help with the MR jet. I'd also, if the patient's hypotensive, and I'd preferentially use peripheral alpha blockers such as phenylephrine or metaraminol rather than combined agents such as noradrenaline. Yeah, that'll be my immediate management.
Are you going to move the patient to somewhere? You had a MECO on the ward.
Oh yes. So the patient will, I think, need to be in a ICU or HDU environment.
Okay, very good. So what had been done here?
Yeah, so that's a coronary angiogram.
It's the same patient, by the way.
Yeah. I mean.
So after you bring the patient down and your colleague decided to consult cardiology.
Yeah.
And then they brought the patient to the cath lab.
Yeah. Gosh. I mean, this is like a picture of PCI that's taking place, but I sort of couldn't comment any further.
Okay. All right. So this is the end of case 4. Any other comments from other candidates regards of case 4? Well done, by the way. It's not easy. So we go back. So remember our case, it's an elderly lady, had a recent surgery, severe hypotension. So not if the patient is hypotensive, the patient is severely hypotensive already. So,
Yeah.
and APO. And the echo findings, I have to say, I agree with most of it. I have to prompt you a little bit on the LV hypertrophic, which was
Yep.
very thick there.
Yeah, definitely.
There may be a slight AR there, as you can see, but that's like minor point. It's really not going to be too much. This one that it is a bit like you can well say that this Doppler, this MO is not well done. Like the lines are not very clear. You know, and the thing that can be seen here, that was occasionally there may be some, but ideally, if you actually look at the systolics from here to here, that actually doesn't really demonstrate a sort of outflow tract obstruction there. See that?
Yep.
At least not obvious. Again, in this picture, not obvious of seeing that, but however, there are outflow tract gradients, and also there are intraventricular gradient as well, as you can see from the picture here. I like the way that you describe of all these jets. I like the way that you're saying that this is a bit more than the MR jet. Do you know why?
Ooh. Is it because patient's LAP is really high?
It needs
Yeah, I'm
to
not
be
sure.
higher than diastolic.
Yeah. Maybe because they're really hypotensive. But yeah, I'm not sure.
Sometimes that we do need to think about, depends on, particularly about Dopplers, like, you know, where we actually line up. So it may not be line up the MR jet completely, you know, because it's quite eccentric jet. So that's why you probably got something that it line up with, you know, the gradient much more than the jet itself. So they may not be in the same plane. That's why you're seeing things differently. Yeah. Emma, do you have anything else to add on this?
Not really, Yang. I think I agree. I think everyone did a great job. I've seen plenty of patients like this, so I did expect him to do well with that tray. Yeah, no, I don't think I have anything to add necessarily. The angiogram slide is fun. I didn't get that one either. One.
Yes.
Sorry, Yang, could you just go over the explanation of why the dagger-shaped waveform is higher than the MR jet? Because I believe there are two different outflow tracts we are looking at, right? One is the LVOT, which is the dagger shape.
Yep.
And the parabolic one is also, or parabolic is the MR, we think.
That's the MR, yeah.
Yeah.
And usually, yes, you know, like usually the MR will be look a bit more than the dagger shape one at the tip, because MR it's going towards to the LA, and the LA pressure is actually quite low.
Much lower, so it should be higher.
So therefore,
as we feel.
then it actually needs to be higher than this. But because the MR is eccentric, and then you may not in that plane you're cutting all the MR, so you're probably cutting the MR in a different angle, and therefore that your MR jet appear to be lower than your dagger shape.
Right.
So if
it's
you
the
actually,
differential pressure, it's the pressure gradient which determines the height, essentially, you're saying.
Just one of those, so this is probably just one of those, you know, like pitfalls that, like, you know, like you probably line up very well with the outflow tract obstruction, but you didn't. The outflow tract obstruction is not exactly at the same level where the MR actually goes. Therefore, then you're cutting half of the MR. Particularly when this MR signal is so faint, then you see clearly much more MR on the color Dopplers. Then this is probably just an angle issue rather than anything else.
Okay, gotcha.
Yeah, but well done with explaining all this. Is super complicated. The management, including with grab the patient to ICU, start those anatropes that you talk about, and then, you know, stop all the Lasix, and then actually give a bit of and the Ventolin, and then give a bit of fillings. You probably want to monitor a patient quite closely, and then refer to cardiology about how to manage your HOCMs. So this is actually septal alcohol ablation.
Oh, okay.
You're right in the way that you did see there is a guidewire there, and you did say it's an angiogram. That's good. Didn't say it's a CT or MRI. That's very good. But the point that this catheter clearly looks very different from the other catheters we use, that you see the two black dot there. So these are ablation catheters. So they're doing the septal ablation there to trying to help her with her outflow gradient. And usually you would notice some pacings or EDP measurements at the same time as well.
Sure.
Certainly not going to be included in the exam, that we're not testing for angiogram, knowledges, but it's just nice to see. Good candidates should be able to also mention that there is no obviously coronary artery diseases that identify on this angiogram where the LED goes down. All right.
Yeah, do you use contrast before septal ablation, the ultrasound enhancing?
No, I think we just done it in the lab, that we're injecting contrast into that septal perforators and then see whether there is any sort of supply, because sometimes those separate perforators are supplying collaterals to other parts of the heart. For example, if they got a blockage RCA or something like that. And in that case, you probably couldn't ablate the septal perforators if they're actually also the collaterals for other parts of the heart. Then you actually induce, like ischemia. So therefore, then we usually just inject the contrast into the septal branches and see that are they actually supply any parts of other hearts apart from the septum. That's yeah. So that's case 4. So we got. Do we just had a new candidate joined, or who want to take on case 5?
I think Rishi and Rob. Anil, are you sitting anytime soon, or Chris? Chris, Guy, and Anil?
I'm not a DDU candidate, so I always, I want to do EDEC. So I'm enrolled in EDEC. So let the DDU guys have a preference, but I'm happy to do a case if you guys hold my hand.
All right. Well, this is yours then. Here you go. So this gentleman, he's 60 years old. He underwent cardiac surgery. All right, and then review the slides one at a time.
Okay, so it's a toe. I'm going to be out of my depth at the moment. I haven't reached to the toe section. Sorry.
In that case, do you want to give the case to someone else?
Yeah, if anybody wants to.
Mm-hmm.
I can do
Rishi, can I ask you to do it? Yeah.
Yeah. Can I go back to the stem, just for a sec?
Not much. Just 60
Cardiac
years
surgery.
underwent cardiac surgery. Yeah. I think this one tells you why this person need cardiac surgery.
Yeah. So this we're looking at a toe mid-esophageal 5-chamber view. What most obvious finding is what is a flail posterior mitral leaflet along with a large anteriorly directed mitral regurgitation jet and a severely dilated left atrium. The LV function and RV function appears normal. I think that's the most concerned finding is the flail mitral valve leaflet.
Can you tell the scallop of the leaflet?
Yeah, so we're looking at likely A1, P1, because we're looking at the aortic valve. So possibly P1, I'll be most concerned about. And this is the mitral regurgitation jet, the direction corresponds to the posterior flail leaflet.
So what had happened here? Still the same patient?
Yeah. So we're looking at again mid-esophageal view. We're looking at the long axis view at the level of at aortic valve. So this is post bypass. We're looking at I think the first one stopped playing.
You did say post bypass, but what has been done? Well, it is post bypass because the heart is beating again, but what has been done?
I can see the
All right, that's okay. What's wrong with the heart here right now?
So right now, I think that I'm not sure the LV is fully filled out, or is the complete return has been going on. LV function appears impaired, and there's again an anterior directed jet. The mitral valve, looking at the mitral valve anterior and posterior mitral leaflets, they appear to be opposing okay. RV size is normal. LA is again hugely enlarged. Aortic valve is opening and closing okay. But I'm a bit concerned about how the anterior mitral valve is opposing to the septal bulge. Whether there is a flow acceleration there, that is a bit concerning to me. So it's anterior systolic anterior motion which is happening there.
Okay, all right. What's this structure here?
Can you play the loop, please?
Yeah, sure. I'll show you the picture before what this heart looked like. Okay, this heart looked like that before. Here you go. That's what it looks like. And now it looks like this. Okay, all right. We move on.
Yeah.
Sorry?
Yeah, I can't comment on that. There appears to be some foreign body there. I'm not clear exactly.
Good, great. Yeah, there is a foreign body there. All right. So, now describe more of your findings. The foreign body is still there. Oh, not just foreign body, give you shadows as well. Yeah, all right.
Yeah.
A shadowing foreign body there inside the heart.
So we're looking probably at a prosthetic mitral valve, a strut of that, which I could be worrying there. So this patient could be having a bioprosthetic valve. So again, a midesophageal view at 5-chamber view. LV biventricular function and size appears normal. And on 2D, possibility of a strut, and the leaflets are moving and opening and closing normally, and a large dilated left atrium. I can see a possibly what looks like maybe a pacing wire in the RA and RV, which I saw it earlier, but not clear was it whether it was just a artifact. But here it looks like it's traversing to the RA and into the RV.
Too many foreign bodies in this heart. Yeah.
Too many foreign bodies, yeah.
And what's wrong with this heart again? Do you mind to point out the pathology?
So yeah, I think mainly looking at a bioprosthetic valve, and whether its placement is causing it to have a LVOT obstruction along with the anteriorly directed jet and causing severe mitral regurgitation. So I'll be concerned this patient might be in cardiogenic shock, most likely secondary to outflow tract obstruction, and secondarily will have trouble with elevated left atrial pressures and pulmonary edema, and will be difficult to manage in terms of hypoxia as well. The positioning of the valve needs to be ascertained, whether that has whether it's been placed very close to the outflow tract, whether that needs to be repositioned. Will be, and I would like to check the gradient across it as well.
You do notice all the cords are attached to the pec muscles. That this, do you think this is a native valve or this is a prosthetic valve?
This appears to me like a native, but I'm not sure what that foreign body. On the left,
there are more foreign bodies there. Looks like a circle.
Yeah, so this could be a mitral valve repair or a ring which they have placed. That probably is along with the native valve which is there, and they and the repair has gone in such a way that this patient has gone into a LVOT outflow tract obstruction, possibility of SAM, and a anteriorly directed jet causing a severe MR. and a large left atrium and elevated left atrial pressures.
So your reg call you overnight that's saying that, oh, this person is not doing very well post-op. Latte is escalating, anatropes are all escalating, indices are dropping, and they can't put the tube out. And then you see the pictures look like this. What are you going to do?
I think in this patient, if the patient is already hyperdynamic, if this patient is already on inotrope, the main plan should be to drop down or to stop the inotropy, give them cautious filling, and to slow down the heart, which is already running at 68, is not terribly tachycardic, and to use afterload agents to increase the afterload with the help of phenylephrine, and to discuss with the cardiothoracic surgeons regarding the placement of the valve, of the ring.
Very good. Thank you very much. This is the end of case 5.
Sorry, it was a bit tricky.
It is a bit hard. I mean, it's so at some point I think that you may not pass this this question at some point, but you managed to dig yourself out. So I think that in the end you're still going to pass, but maybe this one will be a borderline pass because need a lot of prompt. But let's go back to what the case looks like. I think that it reflected when things are not as usual, and when you may be slightly stressed about, you know, like what's actually wrong there. Just remember to calm down and say things only when you are certain. For example, like calling that valve a prosthetic valve, neither mechanical because I mentioned shadows, or a bioprosthetic because there is no more shadows afterwards. That unfortunately doesn't going to score any points and potentially lose points because that's clearly a native valve there. And the foreign body, it's the ring, as you did say in the past, in the end, after a repair. And then the size of the ring, probably it's a bit smaller than what it should be. And then end up with these very elongated redundant valves that cause the post-op, you know, outflow tract obstruction, and which is again quite a common problem with mitral valve surgery. Some of the severe cases actually need to go back to theatre to fix the ring, to change to a bigger ring. The MR is actually much resolved after the fix. So I think that there's another thing we need to be quite careful about, particularly that once you got your DDU, you're mostly going to be there helping your surgeons, you know, to help them decide whether they need to go back or not. Unless you're super certain that MR is getting worse or the MR is getting better. But imagine that if someone just had a 6 hours repair, come back, and then they saw the MR is fixed, and then you ring them up in the middle of the night, the emotions were potentially involved with hearing that the MR is getting much worse, and then coming back, about to take back to theatre, and then find the MR is actually still the same or much less. So just be very careful that there is always a decision to be made with every echo we did, neither to, you know, to do something and not to do something. And when we make a call, then we do need to be careful about, you know, like, you know, other team members' feelings as well. So let's go through this case a bit more. I think someone had a hands up earlier on. I didn't stop. So did someone have a question?
No, that was me. I was just trying to jump in. That's okay.
Oh, okay. Is there any part you wish to jump in, please?
No, I mean, later on, when those images were, the LV function looked down, which could be just you know, the bypass itself. It did not look normal to me, apart from the fact that the patient, I mean, this patient, if they were already on some inotropy, and the LV function is down, if the inotropy, what I'm trying to figure out is I can see a lot of flow acceleration and the valve being pushed into the outflow tract, the redundant part of the valve. If the LV function improves gradually over time, this will actually get worse, is what I was thinking. So do you actually believe the LV function is abnormal here in that image?
Let's go back. I also agree that the LV function probably looks slightly down there as well. Yeah. And that's actually quite common when we fix the severe MR, because the afterload suddenly increase, and also all the edemas and everything intra with the bypass. So this is, again, not that uncommon, but it's not severely impaired. This wire here, I just want to mention again that most likely in the history of cardiosurgery, this is going to be a Swan-Ganz catheter rather than a pacing wire, because they will have epicardial pacings. Yeah. Nothing more to mention on this picture here, that we all see the same. We all see the outflow tract obstructions. We all see these redundant valves, and then the rain is here, and I should give you the shadow. Again, you see the rain here. It's sort of more like a suture line now. And the plan is to notify surgeons and all of that, and you already said that, so that's very good.
I think we might have to, unless you've got time, unless other people are very keen, happy to stay on and extend the session. Are you free? Have you still got some time, Yang, to do that?
Yeah, I
last
got
two
the option.
cases?
Yeah, but
Okay.
if people need to go, that's fine.
I'm
Two
happy
more
to hang
places to
around.
go.
I'm happy to hang around, and
You're happy to go around? Okay, how about you take on this one?
sounds good.
All right, we'll give you the opportunity. So two more to go, all right? 41 years old, very young, presented with STEMI, admitted ICU post-LED with stent, developing worsening shock, Sky C, reviewing the following slides at a time. So this is the transthoracic pictures.
Yep, so this is the parasternal long axis and then short axis view. It's a sort of suboptimal parasternal long that you're showing me here. I think probably taken quite low down. The most concerning feature is the severe LV systolic dysfunction. The apex, which you've shown me, which bearing in mind is off axis, does appear almost dyskinetic. There is enlarged left atrium. It's possible that you're actually trying to show me, it's almost becoming a three-chamber, like an apical three-chamber, apical long axis view there, because you can see how much of the RV you can see. The short axis view is at the mid-pap level. RV size does not appear enlarged in this picture, but again, there's severe LV systolic dysfunction. Just looking at the walls now. So yeah, so like I said, we're at the mid level because I can see the papillary muscles not perfect, but the anterior wall in this picture, almost anterior septal wall, is akinetic and almost in some instances appears dyskinetic. The inferior and inferior lateral wall appears to have preserved function. I'd like to look at that in other views though.
Okay, we'll keep going. And you're saying, the patient is in cardiogenic shock because you identify severe heart failure. So what are you going to do?
Yeah, so we've already done, presumably we've already done an angiogram, but if not,
come back from a stent. You got an LED stent.
Yeah, so we need to support the patient. I'd like to do more of a hemodynamic assessment. Initially, it doesn't appear like the patient needs more volume from these pictures, so I'd probably start an inotrope and see how they respond to that. And if they don't respond, then we need to consider whether they'll need mechanical support. Looking at the whole patient, their urine output, their lactate, etc.
Okay, so if you decide on mechanical support, what has been done here?
This patient's had appears to me like a impeller device placed. So there's a foreign device within the LV cavity, which is traversing the aortic valve. So I imagine that this looks to me like an impeller device that's been placed.
ECMO goes wrong?
Or ECMO goes wrong.
No,
I think that would be a very long cannula, Yang. I don't think I've ever seen an arterial cannula that long. All
right. Okay. Yes, it is an impeller. And what did you see on this picture?
So with offloading, so some volume offloading by with the impeller device, the LV systolic function actually appears to be recruited. a little bit. There's slightly improved systolic function of the LV. In terms of assessing the impeller device, I think depending on the device that's been placed, presuming this has been placed percutaneously, we need to assess whether it's in the right position, and we can assess whether it's working well. But from this single image you've shown me, there appears to be some improvement in the LV systolic function.
How about the RV?
The RV...
I just remind you what the RV looked like before.
Thank you.
That's what the RV looked like before.
Yep.
And that's what the RV looked like now.
I mean, this is not the standard image for looking at the RV size, but it appears slightly bigger in this image. The free wall function appears like there's some thickening and movement of the free wall. But in the setting of improving cardiac output with the impeller, we need to make sure that the RV can cope with that increased volume. I'd like to assess it in other views to see its longitudinal function. Right, so this is a aortic valve, VTI again, that you're showing me. So we can see some, I think they call it vibration artifact from the impeller device there, which is those horizontal lines that you're showing me. And this is a very suboptimal image for reviewing the aortic valve VTI. The velocity scale is not optimized, and there is significant sort of, it's not going to be an accurate measurement, but what you've shown me is a very low VTI, which would be concerning. In saying that, the 2D picture shows me that the angle of incidence compared to the direction of flow is not going to be parallel. Yeah, so it's difficult to comment. Yeah, that's what I'd say about that. This is strain imaging of.
So this is 5 days later already.
Yeah, so 5 days.
And the impeller is out.
Yeah, so strain imaging with your typical apical 4, 2, and 3 chamber views. So you can see, particularly from the color mapping, I find that useful. There is a white area with reduced velocities at the apex, particularly the anterior septal apex and inferior septal apical regions, which is consistent with the LAD infarct that the patient has had. Looking at the other pictures, which are quite small, again, anterior septal at the base as well as reduced strain, with relative sparing of the other components, albeit they are all still reduced, with normal strain being -18 to 22. So still slightly reduced in those other segments, but the most affected areas in the apex and the anterior septal walls. Right. I think and looking at the mapping and the tracing, it appears like the tracing has been done pretty accurately, I think.
Mm-hmm. So it's believable.
Believable, yeah. And it matches with the clinical picture as well.
Mm. What is the difference between peak systolic longitudinal strain to time to longitudinal strain? Time to peak longitudinal strain?
So the general measurement that I quoted is for -18 to -22 is the peak systolic longitudinal strain measurement. So we'd normally use global longitudinal strain would be the thing that you use. Time to peak longitudinal strain is, I guess, what it describes. So how many milliseconds it takes to get to the peak strain. Mm-hmm. And so areas which are more prolonged are going to be the areas which are most affected. So you can see that the values around the apex are high. I don't recall the normal values though, because this is not something I report regularly. I'd have to look it up.
Okay, very good. Thank you very much. Well done. I think this is end of case 6. We'll have a quick discussion about this and then we'll move on since we're already out of time. Any comments? Or I just want to congratulate you, at least that you recognize that's an impeller devices. That's fantastic, because not many people are actually seeing impeller devices. I like the way that you describe it, that you want to know whether it's a surgical implant 5.5 or it's a CP. That look at the petal, that's probably a CP. That's good. And we talk about the heart, you name all the walls, you identify it's a LAD infarct. So that's all pretty good. I think the end of that, I throw you into some sort of difficult questions about this, because that's not something we regularly look at. Emma, do you want to mention anything more about the time to pick longitudinal strain? Then what sort of timing we're using for those numbers?
So, I mean, I don't use this regularly in my practice, Yang, but from my understanding of it, it's sort of, it gives you an idea of the efficiency of the ventricle, and it tells you a little bit about, you know, that systolic, diastolic coupling or uncoupling, like if it's really low. So basically, the lower the longer the time to peak strain, the less efficient that ventricle is. And it probably tells us that, as I say, a little bit about sort of the coupling between like the actin, you know, like releasing the actin myosin going between systole and diastole. But I must admit, I just look at global longitudinal strain and the usual things sort of in oncology clinic reports, and it doesn't really form part of my usual practice outside of research studies. We're currently doing a research study looking at LV strain with the coupling and myocardial efficiency. Actually, this is kind of what we're looking at, but it's very much in a research domain. So I don't use it in my clinical practice. So I couldn't be any more nuanced than that, really. Do you use it regularly, Yang?
No, I have to say I don't use that regularly. And I do see EP people use that when they're doing their resynchronizing therapy and trying to time the ventricle to get the maximum efficiencies. Yeah, but look, in clinical life, that I usually look at these ones. But to be honest, I usually look at just 2D pictures, and then if need to be more, then I look at this sort of other things in more detail. So, but I think that this case is a very hard case, and well done. I really don't have too much to add in. The tiger stripes, you clearly see those before. That's good. This one I particularly want to say that, did you see actually the apex? And apex also involved the RV as well. Those are like big red around LADs that they actually supply part of the RV as well. If you can mention that, that would be perfect. But I still think it's a very good pass for this case. I just mentioned to you to look at that RV there, and you can sort of seeing that as well. It almost looks like a McConnell sign, but it's not a PE. Yeah. All right. So final case. Who want to take the final case? It's going to have to be an easy one to give us a good day to say goodbye. So. Any takers for the final case?
I can do it, yeah.
Okay, all right. Let's try this. So this person is 65, had a MECOR with severe hypotension apparently. Hang on, let me just move these things out of the way. CCU, already in CCU, so heart problems, or had a posterior AMI a day ago, and then fell RCA stent, and then had a MECOR for hypotension requiring inotropic, looks very shut down, anuric and raising lactate. So everything looks pretty bad, so probably Sky CTD. Reviewing the following slides at the time.
Looking at past and long axis views, LV size and function appear normal to me, and so is RV outflow tract size, and RV outflow tract function appears normal. LA does not appear enlarged to me in this view, and so is the aortic, the root. We said that the image quality is not the best at this point. It's difficult to comment on the regional wall motions. Again, looking at the Pascal short axis view, in this view, the LV size and function appears normal. There is interventricular septal flattening with a severely enlarged right ventricle with reduced radial function. The IV septal flattening appears to be there in systole and diastole, suggestive of pressure and volume overload. On the color flow, there appears to be a some kind of defect in the septal wall with flow flow going away from the flow, towards the flow, maybe a decreased a jet from the left ventricle to the RV, which makes me suspicious of a VSD. Again, subcostal views suggesting the 2D picture. This is clearly in the showing a defect in the mid ventricular septal, in mid ventricle in the septum, and showing a large regurgitant, large flow from the left ventricle into the right ventricle. So this makes me suspicious of a ischemic VSD as a complication of the MI. So again, Doppler trace suggesting of a predominantly left to right shunt with some flow going in early diastole to in diastolic phase from RV to AV, but a predominantly a left to right shunt with suggestive of ischemic VSD. So management, I think the initial step is to stabilize this patient. Depending on how severe is the shock, this patient may need ECMO to support the ventricles and to offload the ventricles. Short of that, I think it will need supportive management mainly and discussion with surgeons. Usually they like to do a delayed closure of these ventricular septal defects because of the chance that even if the repair, that's not going to hold. So they like to do it in a delayed fashion after a trial of supportive management when the edema settles. So in this case, if the patient needs ECMO, will go for it. Otherwise, will supportive management with inotropic and vasopressor therapy, intubation and ventilation, and diuresis on this patient. Also having to look for discussion with the cardiology colleagues if there is any other option of inserting a balloon pump to support the coronary circulation as a temporizing measure.
Very good. I have really not much to add. That will be a clear pass. You definitely identify the VSD. You identify that it was a post-infarct VSD. You identify that it's mainly left to right shunt, and then you lay out the surgical plan very clearly. So I couldn't really say anything more in this case. And well done. Any other comments on this one before we call off the day?
Just one thing, the continuous wave Doppler, I think it would be fair game for a point and shoot, you know, to say something like, how would you calculate RVSP or something from that trace? So just be ready to sort of have those kind of point and shoot things ready as well. Especially in the American exam.
Yeah.
Because I know a few of you are sitting the ASC exam. Another I was reminded of on the other case, Yang, with the septal ablation, a favorite American question is the little cameral coronary fistula. So that little blue flow that you see coming out from the septum. They like to sort of show that loop and say this patient has had a post-Holcomb, like post-septal ablation, like what is this? And it's a cameral coronary cameral fistula, just like a small thing, but it does seem to come up a fair bit in their sort of question banks and things. And I guess that could be shown in a Viva as well. It'd be a bit mean. And then I just had one question for you, Yang, about the, sorry, I know we'll massively be over time, but about the mitral valve prolapse case. Did that patient have mitral annular disjunction? It looked like the posterior leaflet was jumping away from the myocardium. It looked like there could be some MAD going on. And I wondered whether they did put a pacing lead in are like a defib when they repaired. Oh, you're muted, sorry.
Sorry, is that the
Yeah.
mitral valve surgical case that you're talking about?
Yeah, you know, the
Yeah.
initial loop, it looked like there was
back. Hang on.
It looked like there was MAD as well with that. Whenever you see mitral valve prolapse, guys, you need to look for mitral annular disjunction because it has huge clinical implication for the patient. They're at risk of sudden death, and they need, surgical input and ICDs usually. You see that on that 2D loop, the initial one, not the one with color so much, but the other one. You see there, like that end part where it sort of comes away from the myocardium. You'd want to look at that in more views, maybe.
Sorry, just a quick question on that image. It's not really related to MAD, but I mean, that looks like a flail leaflet to me, but I remember learning that if the leaflet tip is towards the ventricle, you'd still call that prolapse. Or is it so severe that you would just call this one a flail?
Yang and I can both. I'd call it a prolapse, but
Okay.
I might call it. I don't know. I'm happy to be corrected on that. It looks like it's still curling down towards the. Yeah.
It's like this one is a bit debatable because this one is such a big gap there.
Yeah.
I think that I see people calling those prolapse or severe prolapse.
Yeah.
And I also see those people calling that fail. But if you actually look back to the guideline, like to be really pedantic, then yes, you're right that the tip is curling towards to the ventricles, and this is probably still a prolapse, but just a terrible prolapse. But if you use another criteria, if you actually use the annular line, and this one is already above the annular line, so therefore you can probably equally won't be wrong to call it fail. So I think that regardless whether we call it fail or prolapse, that in the end of the day that this valve need to be fixed. But yeah, great pick though about that MED. I think most of my MED are actually diagnosed using MRIs. Like the echoes can suggest it of there may be a MED, but the exact degree of that it's an MRI diagnosis. I'm not sure. Maybe with 3D echo you probably can do that as well. The picture is super good.
Yeah, they tend to get cardiac MRIs at Nepean as well with FASE Pifan, because they get like late GAD enhancement or something like around that with when they've got that.
Yeah, it's associated with cardiac death and also associated with a lot of like arrhythmias as well.
Yang, thank you so much for taking all of this time out of your day. I'm sure the candidates all very much appreciate it. We'll continue to do lots of practice before the exam. Any final questions, guys, before we end the session?
Yang, in the exams, will the management plan be asked as well?
Yes, there will be management plan asked, and I don't think those management plan is going to require you to go into great depths. It's mainly about like a big principles, but however that it will be asked.
Thank you so much.
All right, thank you so much. Yeah.
Thank you very much.
If I don't see you again, please good luck in your exams, and I'm sure I will see you this August if you're sitting. All right then, bye.
Thank you.
Thanks, Yang. Bye.
Bye.